So again, thanks for being here. I'm Dr. Murphy, as Bruce mentioned, or just call me Sean. So I'm the director of the CHERISH consultation service, and so if you do have any questions about that at the end of this or at any given point, I'm a good person to grab for sure. But any of these fine CHERISH people can help you out. So I'm going to talk to you today about just quality-adjusted life years and health utilities and all those kind of things. So some of you may know some about that, but hopefully there will be plenty of new material in here regardless of where you're at. But please stop me at any point if you have questions. So let's see. Oops. Okay, so the first thing is we want to talk about just the rationale for cost-effectiveness analysis. So Dr. Shackman did a great job, obviously, going through all the different kinds of costs that we want to consider and how to go about calculating those and all of that kind of stuff. So the question is then, well, why do we need to go any farther, right? Why do we not just stop there? I thought econ was just all about cost. Well, the truth of the matter is that if we really want to ensure an efficient allocation of resources, which is kind of that famous economist tagline, right? We have to evaluate both costs and effectiveness, okay? And we all know, right, the important thing about the reason we always talk about an efficient allocation of resources is that we want to make sure we're getting the bang for our buck, right? Scarcity is a big deal no matter what we're talking about with regard to resources. We only have so many. What are we going to do with them, right? How are we going to, let's say, help the most amount of people? And that's kind of what we're going to talk about in this portion. So if we only focus on cost, then the issue is that we may end up choosing interventions that are far less effective. And that's kind of the big concern that a lot of people have that just really don't know much about economic evaluations and things like that, is they think it's just about cost. Well, that's not the case, right? But at the same time, we got to be careful by relying on effectiveness as well. We can't rely solely on effectiveness, because if we do that, there's a good chance that we are going to end up choosing interventions that, although they're more effective, maybe they're just slightly more effective. At the same time, they might be much more expensive. Well, the problem with that, of course, is now the opportunity cost associated with that, meaning that now we have taken this chunk of money that we could have put to a number of different things, right? Fixing the potholes in your roads, educating our children, so on and so forth, and we have allocated that to this more effective intervention, but we haven't really gained that much, right? We might have been better off by using the slightly less effective intervention and using that other money for something else altogether. Okay, so that's really kind of the point in how we're going to bring all of this together in the end, is that we want to look at both costs and effectiveness. Okay, so what about effectiveness? Well, really there are a number of different things that we can include, right? As long as we're just looking at whether one, we're always comparing one intervention to another, and we're going to get much more into this later. Dr. Linus is going to give us a great overview of cost-effectiveness analysis. But at any rate, we can really put anything in there, and especially if we're looking at a specific disorder, there might be some clinical measures that are very helpful and very useful and very intuitive, right? If we're looking at substance use disorders, for example, we may want to talk about days abstinent or a symptom-free day gained, overdoses prevented, or we may also want to look at, say, life saved, life year gained, or what we're going to spend most of our time talking about, the quality adjusted life year gained. And so I'll motivate the use of that a little more. Okay, so like I said, some of the nice things about those clinical measures of effectiveness are they're easily available, they're understandable, right, depending on who your population is. On the same time, though, they're not comparable across diseases, okay? So obviously we can't necessarily compare an abstinent-free day for a substance use disorder intervention to some, cardiac intervention. That's just not going to work. They're not comparable. The other problem, or another problem with relying solely on these clinical measures, is there's no commonly accepted value thresholds, which will make more sense as we start talking about putting these things together and cost-effectiveness analysis. But there's really not this general value in society where we can say, okay, well, we're willing to pay this much for a symptom-free day. That's going to depend very much on the individual stakeholder. Whereas with quality adjusted life years, we do have that to some extent. The other thing is they don't account for these broad ranges of health outcomes that are associated with most chronic conditions. Okay, so we've got one more symptom-free day or one more day of abstinence, but what does that mean? There's so many more things that we want to look at with regard to substance use disorder or any other chronic condition. It's, the individual is going through a lot more than we can capture in, let's say, one day of abstinence. Okay, so, what about these gains in survival? Well, those seem like pretty good measures, right? Lives saved, life years saved. Well, one nice thing about life saved is it's objectively measured, and it weights all lives equally, okay? Well, that may or may not be a good thing, right? It kind of depends on what our preferences are as a population, and research has shown that we may be willing to pay more for certain years of life for different populations, say for children versus others, and so on and so forth. But anyway, so maybe we don't want to weight all lives separately, all lives equally. What about life years saved? Well, again, objectively measured, that's a good thing. But then at the same time, they tend to weight the young more than the old. Okay, well, maybe we want to do that, maybe we don't, right? But that's something we definitely have to take into consideration. Okay, some further limitations when we were talking about lives and life years is, first of all, not all health interventions save or prolong lives. All right, well, now what do we do, okay? And then also there's the whole quality versus quantity issue. We've all, I'm sure, had the unfortunate opportunity to observe somebody who was suffering, let's say, from cancer or something like that and had to undergo chemotherapy maybe, right? We know that is prolonging life, but we also know that the quality of those additional years may not be as high as they would be otherwise. And so that's, there's always kind of that decision is, okay, well, we're getting extra time, but is it good time? And, what would we prefer? And then we also know that individuals may not value health in the same way at all stages in their lives. Health generally varies over time. Okay, so those are other factors that we have to take into consideration. Okay, so then why incorporate quality of life? Well, quantity of life, as we just discussed, is really only one aspect of health. Okay, there's multiple impacts that may be important. So we're talking about the benefits and side effects associated with an intervention, for example, and just kind of those wide range of effects that we want to capture. So quality of life is increasingly becoming an important health outcome for consideration, right? And ideally something that we would want to incorporate into any measure of effectiveness that we're using. And patients are also interested in functional capacity and well-being, as they should be. Okay, so in terms of assessing health-related quality of life, these are health status measures. They're generally derived from psychology. So there's an emphasis generally on rating specific domains of health. So for example, physical, functional, psychological functions, social function, role impairment, right? And then we can map those to specific health states. Okay, so how this works, for example, and we'll go through some of the different measures here in a minute, but let's say we take the EQ5D. So the EuroQAL 5D, it has 5 dimensions. Okay, so there's 5 dimensions that we're asking about, and so there's only 5 questions. Mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. Okay, and then there's the most common one is the 3L. There's also a 5L, but they haven't really done much with it in terms of what we're interested in yet, so we still focus on the 3L. And it has 3 dimensions. So, for each dimension, there are 3 levels, I should say. So 1, no problems, 2, moderate problems, 3, extreme problems. So then what we do, or we have an algorithm that does, I should say, is that we take all these different dimensions and all these possible scores, and we combine them to create all these different health states. So with the EQ5D3L, there's 243 unique health states. Okay? Well, great. What do we do with those health states? Well, for starters, we know that people have preferences, right? And we know that with regard to these different health states, you're going to either prefer A to B or B to A, or you're going to be indifferent between the two, so on and so forth, okay? So the next thing we want to do is we want to translate those into utilities. And I will tell you why in a second. Okay, so what is a utility? Who here can answer that? Everybody's probably had like Econ 101, right? What is utility? Sorry, I couldn't hear, but I'm going to assume you said it's a measure of satisfaction, right? So that's what it is. Basically, when we're talking about utility, we're just talking about happiness, satisfaction, right? Okay, so utilities, why do we want to use those? Well, utilities incorporate values and preferences for different health states. Now, one thing we know about utilities and values is that they're related, okay? Because, for example, the more preferable a health state is, the more valuable it's going to be. So the more I prefer something, the higher the value I'm going to place on it. Utilities also allow us to incorporate morbidity and mortality into a single measure. So essentially what we're going to do, not to jump ahead too much, but we're going to take these health states and we're going to assign a utility value to them. So we're going to weight them, right? And the same thing with kind of this time spent in a given health state. We weight it with this utility value. The other nice thing is that utilities are just a general measure of satisfaction, right? Meaning that they're comparable across different interventions, diseases, disorders. So to really understand what utilities are, just in case it's been a while since you had Econ 101, is, and we won't go completely in depth on this, but first of all, death, how we generally deal with utilities when it comes to economic evaluations and quality adjusted life years is that we translate these health states into this 0 to 1 scale. It doesn't have to be 0 to 1, but that's generally what it is. So 0 is associated with death, right? So if you're dead, you're not happy, supposedly. Okay. The scale should possess interval scale of measurement properties. What that means is that each value is unique on that scale. The values have an ordered relationship, right? So a utility of 0.5 is better than a utility of 0.1 and so on and so forth. And there should be equal intervals, theoretically. So the differences between those scale units is constant. The other thing that we have to remember when we're talking about these health states and tying them to utilities is that utility is related to utility related to one health dimension is independent of the others. So for example, how I feel about morbidity or how I feel about the pain and discomfort is going to be different than how I feel about the anxiety and depression, right? They don't overlap. So when we've got those 5 dimensions. Oops, I went too far. Okay. So how do we calculate utility values? Well, one way is we can measure the values directly in appropriate subjects, and we'll talk about each of these more as we go on. We can use an algorithm to translate the health status domain measurements into utility weights. We can also search for relevant published utility values in the literature. So for example, if you go to the Tufts website, they have the Tufts group there, which is led by Peter Newman, who's the primary author on the new book that Dr. Shackman was talking about. They have a big registry of cost-effectiveness analyses that have been done, and you can do a lot of great searches, and it's a very handy resource, especially if you're doing modeling, health economic modeling. Okay, so let's start by talking about direct utility assessment methods. So these are the primary methods if you're going to assess utility directly. One is just the visual analog scale, or often referred to as a rating scale or a feeling thermometer, and I'll show you that in just a second here. Another is the time trade-off method, and another is the standard gamble. Okay, so here's a good example of a feeling thermometer or a rating scale. This is a really simple example, but basically all we're doing is we're asking the individual to rate how they feel. Okay, so 0 is death, 100 is perfect health, right? And then you just tell them, show us where you're at, okay? And then whatever that is becomes your utility value. So like I said, we want to make it it's an index value. We want it to be between 0 and 1. So if you say I'm 65 out of 100, then of course that's 0.65. Okay, so the second method is the time trade-off method. And in this case, we're basically asking the respondent to state their preference, right? And this is the thing to consider, and I'll talk about this in a minute as well, a little bit more, but basically for one of these values to actually represent a utility value, there has to be some measure of preference. So that's one of the problems with just the feeling thermometers. There might be a scaling bias because, right, you're just asking the individual to rate how they feel, as opposed to actually making them, asking them to make a choice, right, to have some kind of trade-off. Well, so this is a little more of a true utility than say the rating scale, but it still doesn't quite satisfy all those pieces for those what we need basically for it to be required for a utility. But so with the time trade-off, you, for example, could say, okay, well, you can live 20 more years with a severe opioid use disorder or 10 more years in perfect health. So which would you choose? And if the individual says, well, that's a tough choice, I'm completely indifferent, then you would say, okay, so your utility then would be 0.5, right? So that 10 divided by 20. Or, you can live 20 more years or 15. So you basically just keep adjusting this figure until you find the point at which the individual would be indifferent between those two choices. And then that theoretically would represent their utility value or their level of preference for that particular health state. Questions? Okay. Oh, sorry, I didn't realize that was automated. Okay. Okay. The other is the standard gamble. Now, this is the most preferred method. This method actually does give us basically the truest measure of utility out of all of these methods. And part of the reason, well, actually, I might have this on a future slide, so I won't go into it yet, but the standard gamble it basically gives you a hypothetical choice between life in a fixed health state for a given period of time or a two-outcome gamble whose outcomes are perfect health or immediate death. I am not able to access this link because I don't have a computer up here to do it, but if we could, and I recommend you doing it after the break or whenever you have internet access, but it's just kind of this fun little example where you go through and you choose one state or the other and basically you keep clicking until you find the point at which you're indifferent. But the thing is, it's a little different than the time trade-off because it also incorporates these measures of probability. So here's an example. I know this is kind of blurry. Hopefully you can see it better on your slides. But this is an example that Dr. Shackman and some of our other colleagues did with regard to basically using this method for individuals with an opioid use disorder. And, the population was not individuals with an opioid use disorder, but that was what was represented here. They were assigning quality of life weights to these different health states associated with opioid use disorder. And as you can see at the bottom of the screen, is basically what I was talking about on that website where you can click and say, okay, is this good or do you want to keep going? Basically, I would still prefer this, or am I indifferent? But you start with basically just this explanation of what this health state looks like, right? So you're explaining to the individual, if you had this disorder, if you were in this particular health state, these are the kind of things that you're going to be going through, right? And then you say, okay, so given all of that, let's say that I could present you with this option to take it all away, right? So here's this magic pill or this surgery or whatever the case may be, and if it's successful, you will be perfectly healthy. You'll be completely, void of anything that you've been suffering from, okay? But if I screw up just a little bit, or if I haven't, made this pill just right, you're dead, okay? So it's kind of a tough choice, right? So they say, okay, well, I need more information than that. So we give them probabilities. Okay, so probability that this is going to be successful is 0.7, 0.8, or whatever the case may be. And, you kind of start to think about that. Well, 0.8, that's pretty good. That's still, 0.8, I might take that, but at the same time, that's still a 20% chance that I'm gonna be dead, right? So you start messing around with that, and it obviously is gonna depend on how bad that particular health state is that we're describing. Okay, well, do I really wanna live with this, or do I wanna take my chances? And so you can kind of see how that all starts to come together and come into play. We've got this preference consideration, what do we prefer, but then we've also assigning these probabilities to the outcomes. Anyways, it all comes together and gives us, like I said, this true measure of utility. And I'll come back to the study in a minute and you can see what they found. Okay, so just a quick recap of these different assessment techniques. Like I said, so the visual analog scale, it's great in the sense that it's really easy to administer, right? You're showing them this card and saying, here, pick one, pick where you're at. The problem is it's not preference-based and therefore does not arise from economic theory. So then there's the time trade-off method, right? Well, the time trade-off method, like I said, a little closer to a true utility. It does take a hit at the end of life because eventually you start running out of years to trade, okay? And it does not require consideration of uncertainty. So there doesn't have that probability in there. So that brings us to the standard gamble, and like I said, it's basically the truest measure of utility out of the three for sure. It's obviously a little more difficult to administer. The nice thing is it places all the risk up front though, right? You start out in this condition. So you have this condition, but I might be able to take it away for you, okay? So it places all the risk up front. It's directly related to decision theory because it incorporates these attitudes towards risk. And then it accurately describes the risk associated with many medical decisions. So like I said, surgical intervention or the pill is a little more far-fetched, but you can kind of see how that works. Okay, so let's say we're going to set this up. We're doing some modeling. We're going to set this up in a decision tree or whatever the case may be. But we have basically how we can think about this is we have these two different approaches to treating a specific disorder or a specific issue, right? And we want to know, okay, well, which one are we going to choose? Let's say costs aren't an issue at this point. And if that's the case, what we need to do is we need to calculate this expected benefit for each alternative. And this is where those preferences come into play. And so let's say that if we get relief, they're going to associate that with a health utility value of 1, so perfect health, okay? Death, of course, has a utility value of 0. And, amputation, well, that's obviously kind of in between the two. So let's say we associate utility of that at 0.6. So we can say, okay, well, if you decide to undergo amputation, there's a 0.6 probability that you're going to experience complete relief. There's a 0.4 probability that you're going to experience death, right? And the symptom, if you keep that, right? If you don't undergo the amputation, then there's a 0.8 probability that you'll experience relief or a 0.2 probability that you will have to do that. So we'll have to get amputation. I'm not sure this is set up correctly. But at any rate, you could say the expected utility of amputation then would be 0.6 times 1. So basically all we're doing, like I said, is we're just weighting that outcome by the probability of undergoing that. So 0.6 times 1 plus 0.4 times 0, meaning the expected utility of amputation would be 0.6. So on average, if we were to run this a whole bunch of different times, right, on average you would expect the utility of 0.6, okay? Same thing with the symptom, 0.8 times 1 for relief plus 0.2 times the amputation, 0.6, and you can see that, okay, in that case, we would expect the utility of 0.92, right? So we would obviously want to go with that. And it's kind of one of those things that, you realize when you really start to think about this, that this is something you do every day with all kinds of things, right? You decide, okay, well, I'm gonna come to this particular presentation. Well, there's certain risks, of course, associated with getting here, right? I mean, it's risky just driving through DC to get up here or flying in or whatever the case may be, right? But you also realize, okay, well, there's this certain benefit associated with being here. I'm gonna come out and I'm gonna be just this much better person when I leave here, right? I'm gonna have so much more knowledge and all of these things. And you know that the probability associated with that is very high, right? But you also know that, well, the probability associated with something happening to me to get here is also probably pretty low. So even though the value associated, the cost associated with that might be extremely high, the probability of it happening is so low that in the end you decide, well, the expected benefits of coming far outweigh the expected cost, right? And so that's basically all we're doing here, okay? It's like I said, it's something that whether or not you realize that you're doing it all the time. Okay, so the other thing we can do, the second thing on our list, is we can use an algorithm to translate health status domain measurements into utility weights. So we can use these different instruments that we have. Some of you have heard of these, I'm sure, like the SF36, the SF12, the EQ5D, and there's lots. All right, well, I'll spend a minute explaining to you the difference between these things. But we can use those and we can translate them into utility weights. So first I'm going to break these down into some different groups. So if it's preference-based, then that means it's something that is translatable into health utilities, and if it's not, it's not, right? But we can still use it as a measure of health-related quality of life. So that's one thing that we have to remember, is that all of these different health-related quality of life measures, they do have, they have utility, if you will, in and of themselves. So you can use them just as a profile instrument to say, okay, well, how is this individual doing over time in these specific health domains? But if you want to use it in an economic evaluation to calculate quality adjusted life years, so you can do a cost effectiveness analysis or what have you, then you have to be able to map it to that index value that we talked about, right? You have to be able to map it to a utility value. So these are some of the examples. Like I said, so, there's generic and there's disease specific. I guess I should start there. So generic means we can give it to anybody, right? We could distribute the EQ5D right here and everybody could fill it out with regard to how you're feeling today. This is, I would rate these 5 domains with the 1, 2, or 3, and it's just kind of a generic, right? The disease or disorder specific ones, of course, they're not going to pertain to you unless you have that particular disease or disorder. It's just not going to make much sense, right? So, okay, well then, what do we go with? Because in general, it seems like we would want to use the one that is disease or disorder specific. Well, the nice thing about those is that they do tend to be more sensitive over time. So if you have a particular intervention, let's say for somebody with a substance use disorder, if you have an instrument that is sensitive to substance use disorders, then that's great. We're going to pick up those changes over time. Those subtle changes, we're going to be more likely to pick them up. Whereas a generic instrument, it's a little harder to move, right? Well, one of the problems is that a lot of the disease or disorder specific instruments have not been mapped to a utility value. So we can't necessarily use it if we want to calculate these quality adjusted life years. And of course, one of the benefits of doing that is the generalizability, right? Okay, well, so then, anyway, so we've got these generic, we've got these disease-specific ones, and if you are setting up an economic evaluation alongside a trial, for example, you're going to have to talk to the PIs, or if you are the PI, you're going to have to work with your economist and kind of see, well, what can we do? Maybe you really want to use the SF12 or the SF36 because you've used it in the past, and because you believe that, it's just a better measure for what you want to do. Well, if that's the case, we can oftentimes say, okay, well, let's also do the EQ5D because it's very generalizable, it's very short, there's just a low burden on the individual that's doing it. Or we might say, okay, well, if you want to use the SF36 or the SF12, there we go. So there are instruments like that we can actually map to a preference-based instrument. So that is one nice thing about the SF36 and the SF12 is that they can be mapped to the SF6D, which can then be used for utilities. So there's already a method in place for that. Okay, so that maybe that we can come to some kind of a mutual agreement there where we don't have to give an extra instrument, but anyway, so there are those possibilities. Okay, so as far as the questionnaire-based scales, so an item, we're talking about one question, but like I said, each item samples an aspect from a health construct or domain. So let's go back to physical functioning, right? We might be asking about the ability to walk up several flights of stairs, or walk up one flight of stairs, or do housework, things like that, all right? And then the item response is generally going to be let's possibly binary, so yes, no, or categorical, not at all, somewhat, a lot. Or you could do it on a Likert scale. So I have no problem doing this, or 1, 2, 3, 4, 5. And then a semantic differential, so semantic differential, sorry. So agree, disagree, things like that. So there's a number of different ways that you can do this. And of course, it's just going to depend on how the questionnaire is developed. So in this next slide, I'll show you actually what the SF-36 looks like. So it might be a little difficult to see, but I know everybody else has the slides. But you can see that these first questions are measures of physical functioning, right? And then role, physical, bodily pain, general health, vitality, so on and so forth. And then those can be obviously further categorized into physical health or mental health. Okay, and like I said, so then we can then use this and map it to the DSF-60, for example. Oops. Another example is, I'll just go through a couple examples, but another example is the Health Utility Index, and you can see that it has these different domains, and each domain has a different number of levels. Most of them have 6, some have 5, but you can see also that with these different scales or with these different instruments, you get different numbers of health states, and so there's always some discussion as to what's the better way to go, but there really is not a clear answer on that, to be honest. So the best thing you can do is decide, like I said, from both a clinical perspective and from an economic perspective, what's going to work best, what's going to kind of satisfy all of our interests. But in this case, this has 972,000 total health states plus dead. And this one's a 0 for dead, 1 for perfect. Like I said, in some cases there are instruments like the EQ5D that can actually value health states that are worse than death or perceived to be worse than death. All right, so how many of you believe there are health states worse than death? Yeah, me too. Right, so the EQ5D can actually pick that up. You don't see it very often, but that is possible. And then as you can see, the EQ5D is kind of nice too, because it not only does it have these 5 different domains and the different questions, and so like I said, you can look at it, use it. It makes for a decent profile instrument, but it also comes with the visual analog scale, and so you can ask participants, how are they feeling on a given day, and that kind of thing, and use that if you want. So this is just a quick example of, this is another instrument. This is the 15D, so it has 15 dimensions. And this is just an example of how you might use it as a profile instrument. So like I said, just without considering QALYs, you might say, okay, well, I want to look at just how this individual is doing at a particular point in time relative to, say, the control, or relative to whatever the case may be, right? And so you can just kind of do this, and you can of course map it over time, and then like I said, you can also take these and put it into that index value and map that. Okay, so what are the mapping rules? Well, so as we discussed, we're going to use one of these instruments, let's say, and we're going to end up with this large set of hypothetical health states, or these different profiles that we've constructed. So then what do? Well, generally what we do is we have people from the general public rate it. So we'll show them, we'll give them a vignette, they'll watch something, and we'll explain this particular health state to them, and then we'll give them the standard gamble question, and we'll have them rate it. So, but that is actually a point of contention sometimes. It's like, okay, well, who should be rating this, right? Should it be the individuals who are actually suffering from this disorder, right? Or should it be the general public? Why would we use the general public? Anybody have any idea? It's a tough question, right? Well, the reason that we would want to use the general public is because if we're looking at this from, let's say, a policymaker's standpoint, or a benevolent dictator, right? If they're trying to allocate these resources in order to bring up society's well-being as much as possible, okay, well, then the question becomes, really, do I want to base the utilities associated with these health states on the feelings of the individuals who are suffering from this disorder or on behalf of the individuals for whom these decisions are being made, right? Because the general public, some of them might have this, some might not. But obviously, if you hopefully you have a kind of a representative sample, and you can get, this is how we view this. And a lot of times, actually, you find that people with a specific disorder, something they obviously kind of become adjusted to it over time, and how they rate a particular health state might actually be higher than how the general public would rate that particular health state. But the other nice thing is it gives us kind of this a more generalizable value as well, because we can, we're not using the general public to value this disorder and so on and so forth. Okay, so at any rate, so typically what we do is we have the general public rate these different health states, and then we use statistical modeling for weights that represent the public's viewpoint. And so then we come up with these particular values for all of these different health states. So then, in let's say a clinical trial, when we hand out the EQ5D, we do it at a couple different points throughout the trial, and we're able to calculate the individual's utility by taking their health state and assigning the health weight that goes with it, okay? And I'll show you how we use that. Okay, so let's see, the SF6D, some of the mapping rules. So SF6D is based on standard gambles. This is another thing I wanted to mention, is that when considering which instrument to use, you do also have to consider which populations there are values for, right? So for the SF6D, I believe that is only valued by populations in the UK. So if you believe that that's representative of individuals in the US, then okay, go ahead and use it. The HUI which is the Health Utility Index that we looked at, that's valued from one city in Canada. In the EQ5D, another reason that it is so widely used is that there are values from many different countries for the EQ5D, including the US. And this obviously can change over time, so we can, eventually you'll see more instruments with, let's say, US values and so on and so forth. So some of the advantages and disadvantages of algorithm-based indices. The advantage is they're relatively cheap and easy compared to the standard gamble time trade-off utility assessment. So if we use this, it's a lot easier than asking the individuals in our trial directly and then going through and creating this whole mapping thing our own. So we can do paper-based or computer administration. So again, we just give this sample to give this questionnaire to our participants and put the values in the Excel spreadsheet and send it to our economist, and all's well and good with the world, right? And then community-based average utilities, like we talked about, so that's another advantage, is we have these generalizable values associated with these different health states. Some of the disadvantages, the community-based preferences only available for specific countries, and we also are limited to the domains in the survey. So that goes back to the whole thing I talked about a few minutes ago in terms of, it may not be as sensitive as a disorder-specific instrument might be. So Dr. Shackman talked about some of the resources on the CHERISH website. So in addition to the resources on the resource page, we also have, or that Dr. Shackman talked about, we also have different fact sheets, we have blog posts, we have issue briefs. But anyway, one of the fact sheets on there pertains to the trial that we were just talking about a minute ago, and we'll look at the results here in a second with valuing the different opioid use disorder states. And the nice thing about the fact sheets is that you don't have to sit and read through and digest the entire peer-reviewed manuscript. It just kind of summarizes everything nicely for you right there. And then, of course, if you want more detail, you can go to the manuscript. So this is the paper that we were looking at a second ago with Dr. Wittenberg et al. And it is published in Addiction, and we will go through a little more if I can get this to change. Okay, so what they did is they did a cross-sectional internet survey of a U.S. population representative respondent panel. They used the GFK Knowledge Panel. This was conducted in December 2013 through January 2014. They assessed health utility for 6 opioid health state vignettes. So an active injection opioid use, active prescription opioid misuse, methadone initiation, methadone therapy stabilization, buprenorphine naloxone initiation and stabilization. And they excluded responses that failed the invariance criteria. They used survey weights, and they compared the mean utilities across health states with linear regressions to identify significant differences overall and in pairwise comparisons. So this next is the one we just looked at, this next slide. So I'm gonna skip past that. Here is another vignette that they gave to the spouses, because that's one really interesting thing about this study that really you don't see very often is it also tried to account for kind of that spillover effect, if you will. So of course, if somebody is suffering from an opioid use disorder or many other types of disorders, it's not just that individual's quality of life that's impacted, right? I mean, they also have families and caregivers and all of these, different people in their lives that are going to be affected. So this study also looked at spouses and partners and how are they affected because of their spouse or partner's disorder. So here's some of the outcomes from that study. So the top part you could see are the individuals with, or how it was rated for individuals with an opioid use disorder, and you can see that the mean utility was about 0.57 for active injection misuse, 0.69 for active prescription misuse, so on and so forth. So obviously it goes up a little bit as you start talking about initiating methadone therapy or initiating buprenorphine therapy. And then for the spouses, which would make sense, you can see that obviously the utilities associated with those different health states still well below 1, right? But also tends to be higher than an individual suffering from that particular disorder. So, theoretically, they're saying, well, we're not as bad off as if we actually had it, but we are definitely suffering. Oops, too far. So one more thing that they did in the studies, they also provided these expanded vignettes, meaning that in addition to just describing the different health-related functions or health-related consequences associated with opioid use disorder, they also said, okay, well, there's also these other risks that come along with it, right? And start talking about some of those social factors like crime and productivity and all these different things. And I can't remember what all was in the expanded vignettes, but at any rate, you can see that once they were given some of this additional information beyond the particular health consequences, that those health utility values dropped. So the conclusions from the study were that, in the opinion of the U.S. public, injection opioid use disorder results in worse health-related quality of life than prescription opioid use disorder. The methadone therapy results in worse health-related quality of life than buprenorphine naloxone. Spouses, as I mentioned, are negatively affected by their partner's opioid use disorder and early treatment. And health-related quality of life, physical and mental health domains do not capture the full effects of opioid use disorder on quality of life. So, like I said, that pertains to that once they expanded the vignette, how the quality of life factors dropped. So 2 types of summary measures of population health that you'll see oftentimes are health expectancy, which quantifies the current health of a population. With regard to that, we're talking about life expectancy, quality-adjusted life expectancy, quality-adjusted life years, or you'll also see measures of a health gap, which measures the difference between current conditions and a selected target. So you may have seen years of life lost, or one that's commonly used by the World Health Organization is the DALY, so the disability-adjusted life years. And we primarily, when possible, we always focus on the quality-adjusted life years. I mean, the consensus has been that this is still the best measure, but it's not always possible, especially when we're looking at, on a global status. It's not always possible to capture that information. Okay, so quality adjusted life years, they're preference weighted measures of health outcome, as I've alluded to. So the nice thing about the quality adjusted life year, or one of the nice things, is that it integrates both quantity of life and quality of life. And I'll show you how that's done here next. But its main purpose is to be comparable across many interventions, programs, diseases, disorders. It incorporates patient values and preferences for different health states, and incorporates morbidity and mortality into a single measure. So it allows us to have a much broader economic interpretation than, let's say, a disease or disorder specific measure of effectiveness. Okay, so quality adjusted life years, product of two components. So quantity of life, so let's say we're using life years gained, right? And health-related quality of life. So those are the utility weights that we've just been talking about. And basically what we're looking at is the duration of the health state weighted by the value of that particular health state. So what we will usually do is, let's say alongside a clinical trial, throughout the trial, at the different points where the individual is being assessed, we will also give the health-related quality of life weight, and we'll, of course, and as well as a baseline. And they'll say, okay, well, so you spent, let's say, 3 months in this particular health state, and we'll weight that, and then, look at the next 3 months, and so on and so forth, okay? And then basically what happens is, just a simple example is, let's say, for example, we're talking about breast cancer, and we say, okay, for this particular health state, that the quality of life or the utility value associated with that is 0.8. So 1 year with breast cancer then would actually be essentially the same thing as 9.6 months of perfect health, right? Or 2 years with breast cancer would be equivalent to 1.6 years of perfect health. So that's kind of how you interpret those values. And I'll show you a little bit more about how they're calculated. Okay. So like I said, numerical weights are assigned to each possible health state. Again, general range is 1 to 0. But the duration of time, like I said, is multiplied by the weight, and then we sum that up. And I'll show you a graph here, an example, but it's basically everything I just told you. So here's kind of what that would look like graphically. So as I mentioned, we have, we take these assessments at different points in time, and let's say you have, you're comparing individuals with treatment to individuals without treatment. And if you're using a decision analytic model or something like that, you might be able, you're going to be, or you could trace these individuals from the point of the intervention up until death. Or if you're doing it just alongside the clinical trial, you would just observe it over that specific time frame. But the point is, if you look at, let's say, the individuals on this graph with treatment, what we're interested in is the area under that curve. The area under that curve is going to give us the quality adjusted life years gained over this particular time period, okay? And then similarly, we want to get the area under that curve for the individuals in the control group, so the individuals without treatment. And what we're really interested in then, in the end, of course, is the difference between those two. And so usually, when you see an incremental cost effectiveness ratio, how you're going to interpret it is the cost, well, assuming you have QALYs in the denominator, it's going to be the cost per quality adjusted life year gained for the intervention group relative to the control group. Okay? And basically, like I said, this is just a graphical representation of that. We're interested in that area in between. Any questions so far? Or any other questions? Okay. So some of the limitations associated with quality adjusted life years. So first of all, there's this implicit assumption, and Weinstein, this is kind of this famous quote from his article, I think it was in 1988, but implicit assumption that all QALYs are of equal social value. So a QALY is a QALY is a QALY. Okay, well, there's some debate when it comes to that because, first of all, if you are calculating quality adjusted life years, some people, they've shown for specific disorders like specific mental health disorders or things like that, it may not align as well with other disorders. The other issue is that, again, as I mentioned earlier, we may actually value certain lives more than others in a sense. Like maybe we want, as a general public, maybe we want to spend more money on children. So maybe we value the quality adjusted life year for a child a little more than another group, or so on and so forth. So there are these other considerations that we have to take into account. It's not just as easy as a QALY is a QALY is a QALY. But they also may not capture all benefits associated with a healthcare intervention. I mentioned generic instruments tend to be insensitive to some medical conditions, or I should say relatively insensitive. And many condition-specific measures, although more sensitive, are not capable of producing quality-adjusted life years, and therefore not much we can do with them from an economic standpoint when we're looking at resource allocation. Some additional limitations is that preferences may vary by age, gender, race. Evaluation of life years, again, not equal, might discriminate slightly against the elderly. And trade-offs between quality of life and survival, so are many small improvements, for example, really equal to one large improvement? Mathematically, yes, but is that actually the case? Improvement from quality weight of 0.1 to 0.5, is that really carried the same weight as an improvement from 0.5 to 0.9, right? So that whole diminishing marginal utility argument. So this is a nice slide. Again, probably kind of tough to see up here, but it kind of sums up how you get to a quality-adjusted life here. So a lot of what we've discussed. So on the left-hand side, you can see that's a list of some of those generic preference-based measures, and there's already an algorithm that's created, and we can apply that to what we capture from our participants, and then it's kind of just this nice straight shot into producing a quality-adjusted life year. Or, we may be over on this right side where we have a condition-specific measure that we want to use, and this just kind of shows us how we still get back there to produce a QALY, and shows you really how difficult it can be and why we don't have these utility index values for all of these instruments, because it's kind of a long, complicated process to get there and to look at the psychometric properties and all of that stuff. Okay, so just to wrap things up, the quality-adjusted life year combines quantity and quality of life, provides a common denominator for cost-effectiveness analysis. The health-related quality of life instrument is certainly worth incorporating because it has many uses of its own, and ideally you want to use something that, like I said, you could also incorporate into an economic evaluation. And as I mentioned, there are limitations associated with it, but the consensus really seems to be on improving this current approach as opposed to transferring to, some of those alternative measures that we talked about. And this is another good reference that you might want to look up at some point. So again, by Dr. Bray, one of our colleagues, and some of our other colleagues, including Dr. Shackman. But basically, it's just a systematic review of quality of life as an outcome measure for opioid use disorder. And as you can see on the bottom, we agree that health-related quality of life is an important outcome, but treatment programs actually rarely collect this data. So if we're able to increase the use of health-related quality of life measures in the treatment field for opioid use disorder, it really could help inform both clinical and political decisions. I believe that's it. Oh, here's some, at the back of the slide, some resources that we talked about before. So the CHERISH resources as well as the Tufts resource. Okay, well, thank you for your time.